This is Radio Health Journal. I'm Reed Pence. This week, reasons beyond the obvious why osteoporosis is increasing.
It's been clear that the numbers of people with osteoporosis has been increasing, largely because more and more of the U.S. population, if we want to talk just about the U.S., is aging.
Why some people say no to osteoporosis treatment when Radio Health Journal returns.
I'm Nancy Benson, host of Radio Health Journal. If you enjoy listening to Radio Health Journal, you'll also like our sister show, Viewpoints, which covers a wide array of topics from education to history to the environment. Here's a preview of what they're covering this week on Viewpoints.
Many people started realizing that there were also families and children experiencing homelessness.
The homeless epidemic in the U.S. Then,
we made commitments to be on call 24 hours a day. We worked 18, 20-hour days, 7 days a week, no vacations.
The all-consuming world of cults. I'm Marty Peterson.
And I'm Gary Price. These stories in depth this week on your public affairs magazine, Viewpoints.
Listen to Viewpoints on your favorite radio station and subscribe and listen to shows anytime on Apple Podcasts and Google Play.
America is an aging country. By the year 2030, all baby boomers will be 65 or older. That's probably why we're seeing a big increase in osteoporosis. Dr. Sandeep Khosla is a professor of medicine at the Mayo Clinic College of Medicine.
Because it is associated with aging and the population of the U.S., and in fact the world itself is aging, the prevalence of osteoporosis is increasing substantially over time. And so the societal cost of fractures is going to continue to increase almost exponentially in the next 25 to 50 years.
Osteoporosis is a condition which is the result of bone loss, typically, as people age. In women, it's due to the fact that the loss of estrogen after menopause causes a change in bone metabolism whereby bone is lost. More is removed than is able to be put back, so there's bone loss. And that changes the structure of the bone to some degree, making it weaker and therefore more likely to break.
That's Dr. Ethel Cyrus, director of the Tony Stabile Osteoporosis Center at New York Presbyterian Hospital and Columbia University Medical Center. She says one of the most common yet damaging fractures from osteoporosis is a hip fracture. Researchers say about 20 to 30% of patients die within a year following a hip fracture. Another 50% of patients with hip fractures will never be able to move around again like they once did.
Hip fractures can be quite devastating. People tend to break their hips because of osteoporosis when they're in their late 70s, early 80s, and up. So the folks who can least afford to break a hip, the hip being the uppermost part of the thigh bone, when you break your hip, you must have surgery. You get admitted to a hospital, they have to operate on you. If you're already fairly old and you have other comorbidities medically and you're not in such wonderful shape, you get the operation, which typically people survive, but not always, and then you wind up having to go into either a nursing home or a rehab facility or go home in a wheelchair, and it takes a while to be able to get back to your baseline if you ever can go back to your baseline.
While osteoporosis is most often found in those who are older, especially postmenopausal women, there are other factors that can also lead to osteoporosis that are important to know.
Certain medications cause accelerated bone loss and increased risk of fractures, and the dominant one there is corticosteroids or steroids that are used for asthma, not so much the inhaled steroids, but intravenous or the steroid pills that patients have to take for asthma or rheumatoid arthritis or various inflammatory bowel diseases and so forth. And then the list gets a little bit smaller after that. Taking too much thyroid hormone can cause osteoporosis. In young women, excessive dieting and weight loss, such as anorexia nervosa, is associated with osteoporosis. So there's a whole list of other causes but the two big ones are aging and menopause.
Despite the nation's increasing population of people over the age of 50, fewer adults at risk of advanced bone loss and fractures are actually undergoing tests for it. And less bone density testing means decreasing diagnosis and treatment of osteoporosis.
It's really quite fascinating. When bone density testing first became available, and you have to understand, it's a machine that you lie down on fully clothed, and a scanning arm goes over your spine and then over your hips. And sometimes we have the patient sit up and we do the arm as well. It's painless. It takes about 10-15 minutes. It involves an X-ray technician. It's a long, table-type machine that you need a small room to put it into. The machines had a certain price, and you could lease them as opposed to buy them. But back when they were first becoming available, Medicare reimbursed about $150 for the test, which was great because it costs about $75, $80 to perform the test.
However, Cyrus says when Medicare sharply reduced its rate of payment to providers, the test quickly became much less available to patients.
It turns out that there are fewer machines out there, and there are fewer people being tested. And part of it is probably this whole reimbursement issue. And it's very unfortunate because it's an important test, which is a little harder to get to.
At the same time, research started to come out that scared patients away from drug treatment for osteoporosis. Those studies reported two uncommon bone problems in connection with long-term uses of those drugs. One is a fracture of the femur, the thigh bone. The other is osteonecrosis, an even more rare condition where the jawbone begins to weaken and die. Experts say the widely publicized hazards of bone-preserving drugs deterred people at risk of fractures from drug treatment.
We learned recently, and I was a part of the study that showed this, that the rates of hip fracture in the aging population, which had been declining in the era when we were testing and treating, and that meant that they were declining from the late 90s through the mid-2000s, sometime around 2013, this declining rate of hip fracture began to completely level off. And we've guessed, we can't prove it, but we've guessed that a good part of the reason for that has to do with the fact that fewer people are being tested, therefore fewer people at risk are being diagnosed, fewer people are being prescribed medication, and fewer of the people being prescribed medication are actually taking it. And the ability that we had to lower the number of people with hip fractures seems to be disappearing, and the rates are leveling off, and perhaps they'll go back up.
Cyrus says the decline of testing is creating a crisis in the treatment of osteoporosis. But Khosla says there are a lot more options these days to treat this condition with great effectiveness.
We have a number of drugs that are very effective in reducing the risk of fractures. These include 4-bisphosphonates. Sort of the prototypic drug for that is Fosamax or alendronate, but there are 3 other drugs that are in the same category. There's another medication called Prolia that you take by injection under the skin every 6 months. There's 2 additional drugs, teriparatide and abaloparatide, which actually increase the amount of bone that you have as opposed to just stopping bone loss. So there's been huge progress, and it's a disease that, is very treatable and in some cases even reversible.
For patients who are still afraid of these drugs, and there are many, Khosla and Cyrus say the risks of side effects from this treatment are rare.
I think a lot can be done to minimize the side effects. The good news is that, we do have a number of very effective drugs. The concern is that they're not being used appropriately because patients are just shying away from them for concern out of these side effects. And we continue to learn how to best use those tools or drugs to minimize side effects. But because of the concerns that patients and many primary care physicians have and the bad media press that many of these drugs have gotten, it's really an uphill struggle.
Today, most of us, if we're going to give a drug like Fosamax, which is now generic, or one of the other oral bisphosphonates, or even the intravenous bisphosphonate, we usually treat people for maybe 5 years with the orals, maybe 3 years with the intravenous, and then we almost always give a holiday, during which time the bone has a chance to reboot a little bit, making the risk of something like jaw necrosis or the other side effect, which is a very rare, unusual, funny kind of thigh bone fracture in the mid-thigh that's kind of transverse across the thigh bone, something that takes a few days to weeks to develop. Those 2 side effects are really a function of either the dose or the duration of dosing.
Now doctors are aware of these problems and can prescribe to patients properly.
Today, we would give somebody a shorter course of therapy. Some people went on Fosamax 20 years ago and they stayed on it for 15 years. We don't do that. We give it for 5 years. We typically give a holiday, during which time the amount of drug they've already gotten helps the bones and continues to help the bones for a period after stopping. Eventually, after 3 years, after 4 years, sometimes sooner, the drug wears off. And if you still have significantly low bone density, you may want to go back on the drug for a while or change to a different drug. And this is what we try to do. We try to tailor it to the patient. But there's no question that if you've had a course of bisphosphonate, you should continue to be monitored because you may, down the road, after having stopped, need to go back on it for a while.
Khosla says taking the right precautionary steps can help prevent an epidemic of broken bones as baby boomers continue to grow older.
Educating primary care physicians and patients that if there's new onset of groin or hip pain in a patient who's been on one of these medications for a long time, that needs to be brought to prompt medical attention, and further studies such as x-rays need to be done to make sure that the patient isn't developing atypical fracture of the hip.
Since osteoporosis usually affects those who are older, it's crucial to treat the disease sooner rather than later. Hip fractures associated with osteoporosis often complicate other health difficulties a patient might have, and that can lead to critical conditions.
In the case of hip fracture, that's associated with a significant mortality over the first year. Now, some of that is because the people that get hip fractures often have other diseases, but in the context of those diseases, the hip fracture is the thing that kind of tips them over. And, they then get infections in the hospital or other complications and then never really make it out of the hospital. And then another subset that make it out of the hospital end up having to go to a nursing home or assisted care and can never really go back to independent living. The other fractures, the vertebral fractures, are not directly associated with increased mortality, but they cause considerable pain and discomfort and deformity of the spine.
Better education about osteoporosis for primary care doctors and treating this condition case by case can make a huge difference for patients and lower their risk of fractures.
So I think we can be very intelligent about doing the best we can to be prudent, to treat, to give holidays with bisphosphonates as appropriate, and keep most people out of trouble. Now, that means tolerance and safety are quite good. Now, obviously, even if we're perfect in how we do this, and I don't know if we're ever perfect, we are not eliminating the risk of fracture if somebody's got bad osteoporosis. What we're doing is dramatically lowering the likelihood of fracture so that we're making a real difference, but nothing is perfect.
And Cyrus says drug treatment isn't the only way you can prevent injury. Most people can lower the risk of fractures themselves, even if they suffer from severe osteoporosis.
The third part of the picture is don't fall, because really the overwhelming majority of fractures, the problem is that there's a weak bone, and if you fall down, you might break it. If you never fall down, there are a whole bunch of bones you'll never break. So how do you not fall? I think that's a two-part answer. One is, to the best of your ability, stay in the best physical shape you can stay in. Be as strong in terms of your muscles and balance and coordination as you're able to be, given who you are. That helps you be less likely to fall. And the other part of it is mindfulness, is paying attention, is walking down the street and not texting while you're doing it. It's paying attention to the street you're walking on. It's not being in too much of a hurry. If you find yourself rushing at age 72 to cross a busy highway, you want to run across the street, don't do that. Wait for the light to change and walk across. If you find yourself rushing, slow down a little bit.
You can find out more about all of our guests on our website, radiohealthjournal.org. I'm Reed Pence.
A new survey from the National Blood Clot Alliance shows more than 70% of U.S. adults on blood thinners are more cautious about routine activities, and 42% say the risk of major bleeding has discouraged them from trying new ones. The findings also show more than half of those taking blood thinners fear a life-threatening bleed, and nearly 3/4 of that group say it's impacted their quality of life. That's unfortunate, says Michael B. Strife, MD, FACP, Johns Hopkins Medical Institutions.
Blood thinners save lives, but many people taking them are avoiding activities they love, like gardening or exercising, because they're afraid of experiencing serious or dangerous bleeding. That's why talking to your doctor is important to understand how to reduce the risk and learn how bleeding, if it does occur, can be treated.
The good news is that 95% of people taking blood thinners have talked with their doctor about such risks. Visit stoptheclot.org/guide for more.
And that's Radio Health Journal for this week. Radio Health Journal is a production of MediaTrax Communications. Follow us on Twitter, Facebook, and Instagram to learn more. And check Apple Podcasts, Google Play, and Spotify for a library of past programs. Plus, you'll always find previous segments and information about our guests at radiohealthjournal.org. Join us again next week for another edition of Radio Health Journal.
Coming up next week on Radio Health Journal.
To be questioned, to be villainized, that for the majority of them is not what they signed up for.
Why so many local public health officials are quitting in the middle of a pandemic.
Then the under-recognition of PTSD, not in soldiers or first responders, but in children.
Unfortunately, that by the age of 16, 2/3 of all youths in the United States have probably been exposed to some kind of life-threatening traumatic event.
All that and more on Radio Health Journal.